All right, let's go ahead and get things started. Good morning, everyone. Welcome to the Building Clinical Informatics Learning Community, Session 3, Improving Data Exchange, COVID-19 as a Test for FQHC Interoperability. My name is Elizabeth Breidenbach. I'm a Meeting and Events Specialist based in the Clinical Affairs Division here at NAC, and I'm pleased to bring you this event along with my division colleagues. Before we get started, I would like to review a few housekeeping announcements. You have joined this online event by either physically calling in or using computer audio. All attendee lines have been muted and will be muted for the duration of this event. The duration of this live event is approximately 45 minutes, including introductions, presentations, and Q&A. Again, the duration of this event is approximately 45 minutes, including introductions, presentations, and Q&A. If you have questions throughout today's event, please use the chat box located in the lower right-hand side of your computer screen. Simply type your question, comment, or concern into this box at any time, and all panelists will receive this question. Again, please type your comments, questions, or concerns into the chat box at any time, and we'll be able to answer that either throughout today's session or we'll make an attempt after the event is completed. Friendly reminders that today's event is being recorded and will be available on demand after this is completed. All attendee lines have been muted and will be muted for the duration of this event. The chat box is open for the duration of the event, located in the lower right-hand side of your computer screen. If we cannot answer your questions in the time allotted, we'll make an attempt after the event is completed. At this moment, I'm going to turn things over to my division colleagues who will be introducing today's speakers and will be kicking off today's session officially. I'm going to turn things over to you guys, and I'm all ears. Thank you.
Hi, John Gresh here. I'm informatics specialist here at NAC, and today we're happy to be talking to you about improving data exchange and some work that's been done around COVID-19. I'm going to start with introducing our speakers, Dr. Eckert, who will be talking about the Greenlight Project and some of the work that her team has been doing around COVID information and COVID information sharing and using that data and information, and Dr. Carrillo, who will be talking about the immunization registry and the work that they've been doing and the successes both of them have had in interoperability and using data from multiple sources. So to start off, I'd like to talk about some of the challenges we have and what we've learned from our colleagues and where we're headed. So next slide, please.
So John, here, I'll take the next two and then hand it back to you. So, the purpose of the Learning Collaborative is a part of the HRSA NTAPs, the National Health Center Training and Technical Assistance Partners. And the goal of this entire series is to engage partners who have an informatics connection or support FQHCs and their partners doing public health and informatics work. And specifically to build skills to help you understand how electronic reporting, data extraction, data standardization works so that you can support your FQHCs in achieving these ends. Next slide. So the agenda today, we're going to talk first about the NAC data infrastructure, data capture, and data quality, and that effort has been led by John and the other members of our team, including Pedro Carnera, our data scientist, and Raymond Uy, our physician informaticist. And then we're going to hear from the field some stories of partners who work with FQHCs to share data that will augment both the public health components, but also the direct patient care components around providing services to FQHC patients. And the lens that we took on this specific session is COVID-19, because of course we are all embroiled in that and have been for over a year now. We're going to hear from Greenlight, who works to support sort of case management and referrals, and ERA, who works across the nation's immunization information systems and immunization information managers. And then we'll introduce the next session. Next slide. So I just wanted to sort of kick off by providing a lens to think about, it is a significant amount of effort to improve the interoperability of the systems that we use, but we can think of it conversely that the lack of interoperability is very wasteful, actually. And that's because we miss opportunities to act to close care gaps. We miss opportunities to understand our patients' needs. We miss opportunities to bring together pieces so we can validate and improve the quality of data that we have. We miss opportunities to make the experience of care a better experience, both for the patients who frequently are frustrated that we don't know things about them that are known in the healthcare system, and also the providers who experience the same frustration that there are data gaps of things that the patient feels they should have known, or things which would modify, importantly, the plan of care for the patient if those things were known. For example, a patient already tried a medication and they had a bad side effect. If you don't know that, you might give the same medication. The patient's not sort of able to remember that that was a medication they had a problem with, they could experience that same side effect again. So in that vein, we're sort of bringing together approaches that we think will help all of our partners understand how to create better connections to their partners and how to create better quality and standardized data, which is what's necessary to get interoperability working. So I'm going to ask to move to the next slide and hand it off to John. Thanks, John.
Thanks, Julia. So I'd like to talk a little bit about what we're working on with the Cosmos system, our informatics infrastructure here at NAC. Next slide, please. So this is our introduction. Next slide. So we're very much in a situation where we're getting information from multiple sources, from some directly from EMRs, some from hospital systems, some from healthcare centers. We really have a very varied pool of data that we get. It comes in all kinds of size, shapes, and forms. And right now, our job is to kind of ingest that data, transform it, capture it, and clean and catalog it so that we're not only capturing the data, but we actually understand the information we have. And at the end of the day, we can publish meaningful, actionable information out of the system. Next slide, please. But we really are in a situation where we have the data that we're getting and the data that's coming in is coming in really multiple forms. And a lot of the work that's being done to kind of standardize that falls on us. And it turns into a very large job of creating a lot of customized ETL and validation processes. On the upside, this is very flexible and we're able to incorporate data from any format, but on the downside, as Julia mentioned, it's time consuming and there's potential for errors and degradation of data quality. Next slide, please. And so we have, again, there's a process that we have in place, and we ingest data and we review it and we put it into our long-term storage. And we have a number of processes that we do to clean the data and import it and get it into a standardized format. Next slide, please. And so as we move ahead, we're moving towards a web-based import, and we're still going to be able to get data files in from any format, but we're going to automate some of the process and be able to automate putting these data into a standardized structure. And at the end of the day, our ultimate goal is to move towards a standard. OMOP is the standard that we've identified as what we're driving towards. And so when we get there, we'll be able to avoid a lot of that work and a lot of the effort that goes into getting data from multiple sources. Next slide, please. And so as far as data quality is concerned, right now the data that we get in comes in a number of forms, and starting kind of at the bottom of this slide, we get data that is pivoted. So in other words, instead of getting a column of data where it says, here's a list of patients and diagnoses, and here's here's a list of measurements, and here's what the measurement was, we'll have a table that has a column that says this is the fever column, this is the aches column, and there'll be a tick mark as this patient got aches. And there's a lot of work that goes into unpivoting that data and getting it into a more normalized data. We also get flat data. We do get some normalized data. Some of the data sets we have is encoded. We get ICD codes, we get line codes, we get RX norms, but a lot of it isn't. A lot of the medication data that we get, it comes in as strings, and we need to deal with that. And there's a lot of mapping and cleaning that goes on with that. And then we're working towards getting our data into a standardized format that's standardized to what works for us, and eventually migrating that to a standardization that is OMAP conformant. So at the end of the day, again, we'd like to be talking a common language that will eliminate a lot of these problems that we have by accommodating data from all different sources. Next slide, please. So Andrea, we're going to do the poll now.
Hey there, just waiting until I can get control of the screen. There we go. Thanks. So if you would rank, for those of you who've used Mentimeter before, you may have seen this. You go to menti.com on your browser or on a phone. We only have 2 poll questions, and we're going to have to rip through them so that we can get your good thinking and move along. What you do is you go to menti.com, menti.com, and use the code 111-1112-9556. And the first question is a ranking question where you should be able to move them. And I can see that you have already figured it out. This is very interesting. John, do you want to comment on, we've got 2 participants answering.
I'm not seeing it, Andrea.
We're still seeing the slide.
Okay. Let's try that again. Now do you see it?
Yes.
Excellent. I'm glad you mentioned that. So you are all able to see what our 3 participants so far have registered for what they normally use. We've got 4 folks, and that's shifting our leaderboard here. We'll leave this open for another few seconds. So if you're able to go to menti.com and use the code 1112-9556, you should be able to see how you send data.
And Andrea, can we, at the end of the call, maybe during the question and answer, show the final results of the poll questions?
Sure, absolutely.
Yeah, so I'm glad we did this because it does validate what I was saying, that we do see a lot of normalized, flat, and pivoted data, and so that is validating what we're seeing. So shall we move on? And
yeah, let's move on.
Back
and I think we'll ask you guys the same question in a year and see what we say. See what we get. Hopefully the HOMOP will be a larger contingent. Here we go.
So I did want to share just a couple examples. So this is an example of a file that we get in, and in this particular file, we get just a mixture of all kinds of data. We get encounter data, we get demographics data, we get medication data, we get diagnosis data, we get symptoms data. And when I get data that comes in a normalized format, there's that query on the left there that is very easy for me to ETL it into our data model. But for something pivoted like this, the actual ETL query to just get the data out of this format turned out to be 281 lines. So that's kind of the level of effort that goes into some of these data structures that are less formalized. Next slide, please. And then the other, so that was an example of structural things that need to be taken care of. And then there's domain data. So this is an example of, this is just in the COVID testing data. One of the known soft spots in EMR data is lab data, because there really is a lot of vendors out there for EMRs and a lot of vendors for labs. And the systems have a wide range of integration, to being fully integrated and automated, to being actually hand-entered data. And when we have hand-entered data, we get things like this. We have 207 unique values that basically represent negative, positive, or other. And here you can see some of the ones that for negative, other, and positive. So we get negative, we get negative, we get negative, knee. So these are some of the other problems that we face with non-standardized data. Next slide, please. We also wanted to acknowledge that we're very aware that there's a wide range of solutions and level of effort required to resolve all of this. Some cases, working from the top down, sometimes it's just a matter of communication, and we asked for one thing and that got interpreted one way, or somebody didn't realize that there's an easier way to do it, and it's just a matter of communicating that it would really be better to do things a different way. In other cases, information is available, but either we don't have the resources or we don't know where to go look for it, but it is available, and it's just a matter of figuring out how to get it. In other cases, the data is not available. It's not in the EMR, or even worse, it is in the EMR, but for whatever the reason, the EMR doesn't want to share that data, or there's a paywall to get to that data. And so in those cases, we have to kind of work at another level, and that to resolve that might require policy changes, or get, the vendor to change the way they're doing things. And then finally, there's cases where the data just don't exist, the data aren't captured. We see that a lot with social determinants of health, that in a lot of cases that information just isn't captured routinely. And again, that's going to take a different, there's not a tactical solution there. We need to look to strategic solutions for that. And I think that's it for me. Is that correct?
We've got one more quick poll, even though we're a little bit over time on this section. If I could share the screen, Liz, thank you. And this time, hopefully you can see it. Or can you see it?
We can see it now.
Wonderful. If we create, I think we glossed over the fact that we're creating a data lake here at NAC that John is engineering. And the idea is bringing in normalized data so that we can ask questions of it. If you were contributing to a data lake on one of our projects or in general, what are the kinds of things you'd want to get back? And I'm being told that my audio isn't, I hope you can hear me okay. So the question is, if we were to create a normalized pool of data, what kinds of things would you want to get back from NAC? If you're one of our partners or you have an agreement to share data with us, what are the kinds of things that you'd want to get back from a normalized data analysis? Or John, you can jump in and say what kinds of things we'd be sending back. But we'll go pretty quickly here since we're a little bit over time. If you can, go to mentimeter.com, use the code 11129556, and we can come back to these slides if we have time at the end to see what everyone said. So I will stop sharing and we can move on to John and then our next speaker. Thanks.
Sounds good. Thank you. Thanks, Andrea. So Dr. Eckert, take it away.
Hey folks, good morning. Thank you so much. You go ahead and go to the next slide, please. Great. So my name is Carly Eckert. I'm a clinical informaticist and preventive medicine physician. I've been working in industry and health innovation for the last 4 years or so, and I'm the Chief Clinical Officer at Greenlight Ready. I will be talking to y'all today about some of the work that Greenlight has done. We are based in Durham, North Carolina, and excited to share some of this work. So next slide, please. So a lot of the kind of inception of Greenlight stems from some of the work at Duke University and Duke Health from the early days of the pandemic. As some of y'all might have known, Duke had some really innovative approaches to keeping Duke open to in-person learning and in-person classes throughout the early days of COVID. And part of that is actually the Pandemic Response Network, which is called PRN. PRN was launched in April of 2020, and really its goals were to help people stay safe and connected during the pandemic. Really, the principal offering was a COVID-19 symptom support program with a web-based survey that really connected folks to healthcare professionals to provide feedback and guidance to participants on how to care for themselves at home. So this team was actually calling folks across the United States when there were concerns about COVID symptoms, COVID exposures, and really getting some of the expertise from the hospital to communities. This was available in both English and Spanish and was used by close to 8,000 people across the United States. But what some of the study leaders were realizing is that there were really additional challenges that a lot of people were facing, including lack of access to care, food insecurity, and also just lack of access to reliable information about the pandemic. Next slide, please. So really out of some of those needs, Greenlight was born. And so Greenlight really builds on a lot of the work of the Pandemic Response Network, really on connecting people to services, but really with a more hyperlocal approach. So as I mentioned, we're based in Durham, North Carolina, Durham County, and also working in some of the surrounding counties with the goal of really intentionally reaching those communities that have experienced a disproportionate impact of COVID and of some of the repercussions of COVID as well. So we work with the community, with community partners, with the grassroots organizations that existed here before COVID, and really with the goal of connecting people and connecting groups. So we're a really small team of about 5 folks. Many of us have backgrounds in health technology and healthcare and health innovation, and we work to really build community-owned, community-informed technology to connect people and resources during COVID. Next slide, please. So the Pandemic Response Network in particular has been featured by the Centers for Disease Control and Prevention as really a model for developing trust during this time. And that's one of kind of our big concerns in how we intentionally work is with these groups that are already really integrated and invested in working in the community. And one of those tools is really community health workers. And you all are obviously very aware of that and of kind of the skill set that community health workers bring and really of their value. And we worked closely with a nonprofit called Cure Americas Global, which is here in North Carolina, based in Raleigh, and has been able to work with over 200 community health workers, community-based organizations to connect people to the resources that they need during this time. Next slide. So as I mentioned, kind of our hyperlocal approach to this work, we started looking in the summer at partnering specifically with K through 12 schools in the area as well as small businesses. So really thinking about those essential service workers in the community and some of the concerns and anxieties and fears around COVID and some of the common challenges that we saw during those days. And as I mentioned, one of our, I think, skills has been to really flexibly adapt to the changing needs of the pandemic because we're so small and we can kind of move kind of fast. So these needs have changed over the last 6, 8, 12 months, as you all are aware. But some of the early challenges were some of these fears of the unknown, right? We were seeing small outbreaks of COVID among schools and among students and among, small businesses. There was a lack of information about testing, where to go, how to go, how do I have to pay for it, et cetera. There's a need for daily symptom monitoring or attestations for kids to go to school or to be admitted to buildings, and also a gap in knowledge about COVID, really. And there was information everywhere. There was, extensive websites and so much to read, but it often wasn't in the right format or in the right way or accessible to people in the way that they needed it to be. Next slide. So this shows some of the systems and components that Greenlight has been able to build out to really work with local schools and small businesses to open safely and to stay open safely during this time. As I mentioned, we have a web-based application with daily check-ins for symptom monitoring for both schools and small businesses. This includes things like live dashboards for administrators as well as business owners to use to kind of see how their folks are doing. We've distilled a lot of the best practices from Duke Health and the clinical experts there, particularly in infection prevention and some of those policies that were in place at the university and at the hospital, and really made them accessible and implementable in a practical way for schools and small businesses. Additionally, we have included information with access to testing, information about vaccines and common questions and concerns we're getting about vaccines. And also, as I've mentioned, this kind of connection to social services. So how do folks who may have concerns about food insecurity during the time of COVID, how did they get access to community health workers? As I mentioned, these community-based organizations, community health workers have already been there, have our trusted partners in the community, but how do we make sure that folks are able to connect to them in their time of need? There was so much fear and anxiety around COVID that it really helps to have this available at the fingertips of folks when they most need it. Next slide. One of the points I want to make here is that while our platforms are secure and private for folks to share some of their information about symptoms, our approach really with data was to make sure we removed any barriers to people accessing care. And so that meant we didn't share any of our data with health systems or with hospitals. Folks could, we asked folks to submit their name, but that was all when they kind of registered for our platform. That wasn't linked to any EHR. We have done, we're not a research organization. We're really just trying to connect people to the resources they need and try to eliminate any sort of anxieties about where data might be going or flowing for these folks. Next slide. So the next few slides, I have some screenshots of the application just to kind of demonstrate some of the functionalities that I've mentioned. We have here the daily check-in, which enables either parents or students or employees to quickly go through and click on symptoms or exposures they might have had. Again, a lot of the value of the symptom check-in was in kind of the summer and early fall. As I said, the needs have changed and we've tried to keep up with those changing needs. We had ways for folks to kind of quickly click through and have access to testing, have a provider on the phone if they needed to kind of decide if they needed to get tested or how the urgency of that testing, and also ways to be connected to social services and community health workers. Next slide. So this is a screenshot of that symptom attestation page. So again, with 3 easy clicks, folks could click on the symptom they're having or no symptoms, any contacts who've had COVID or a recent diagnosis. And this is again kind of drawing on, we work closely with the North Carolina Department of Health and Human Services, as well as the Duke clinical experts that I mentioned, to kind of make sure everything is in line with current best practices. Next slide. So there are kind of three ends to the tree or leaves to the tree that kind of completed the symptom check-in on a daily basis. Folks could either be cleared, pending, or in recovery. And this kind of icon that would either be green, yellow, or pink would then go to that administrator or business owner to let them know that someone has checked in for the day. This icon is different daily to ensure that we have really the most up-to-date information on that participant. Next slide. So when folks were pending, that status means that folks have reported a symptom or a recent exposure. They would then have that accessibility to be connected to health professionals as well as social services if needed. Next slide. When folks were in recovery, that means they've either had an illness of some kind, whether that be COVID or otherwise, and again, being routed directly to support services. Next slide. This also enabled dashboards, so at the level of the administrator or the employer or business owner, they could kind of see across their cohorts to see who had checked in for the day and kind of what the status of that individual was. Again, really respecting the privacy of those individuals. There wasn't further information available, it's just simply the color of that icon to give an idea of, if that person has been cleared for that day. Next slide. This also enabled folks to see kind of cohort level views of descriptive statistics, as well as kind of an overview of what might be going on in their schools or small businesses. This can be particularly useful for schools to consider different classrooms and how might different exposures be happening. Also, we noticed that some business owners might have multiple restaurants or multiple businesses to they wanted to look at those in aggregate or separately to see kind of how their employees were being impacted. I'll share on the next slide some of the best practices that we were also able to integrate into the app, but you can imagine that you could also consider, if different cleaning practices or where might there be kind of different best practices being implemented and how that could have an effect on COVID and COVID cases. Next slide. So as I mentioned, we've incorporated into the web-based application a lot of these practical implementation guides, and also some of the decision trees in terms of, what to do if an employee or a student is symptomatic, kind of what to do next. We got a lot of phone calls. Part of our offering is also to be available on the phone. And so we're getting a lot of phone calls, help, one of my employees is symptomatic, or, what do I do if an employee comes to me and says they've had a recent close contact? And this was really in August, September, October, when a lot of this was kind of coming to bear for the first time for some schools and small businesses. And so we were able to really walk through with folks in terms of how to do this, who's your first call, how to kind of prepare what you need for the health department, etc. Next slide. So we developed a lot of different resources for schools and small businesses to use. And as I mentioned, we worked closely with Duke Health to develop these and to kind of distill those best practices in the most practical way for schools and small businesses to implement. So we have playbooks, we have toolkits and scorecards and all sorts of things that really are aimed to take some of that burden off of these organizations. Throughout the last year, these groups have been asked, with many other groups, have been asked to do so much more, right? To almost to initiate contact tracing, to do all these things that they haven't been trained in. And so part of our approach was to see what can we relieve people from doing, what can we help with, and can share to other folks to hopefully get people back to their area of expertise, quite frankly. One of the good examples of this is the state of North Carolina enabled rapid antigen testing among its K-12 schools in December. There were a variety of different sort of requirements for schools to be able to participate in this program. And in order to kind of take some of that burden off of them, Greenlight put together kind of a 12-point package of those things that would be required of schools. So we could work closely with the schools, work closely with the local health departments to kind of make sure that all of these points were in order, and to then kind of facilitate that involvement and that participation for schools to better serve their families. I did want to share one of the assets that was really popular was this scorecard down in the bottom. This was actually an interactive survey that administrators could walk through. It was about 50 questions, so it was pretty detailed, but it was a really good way to internally benchmark how schools and businesses were doing in terms of implementing these best practices. It is also weighted, so people could kind of get a sense of where to better invest their time and energy to really have the most impact on how well they're doing in terms of benchmarking themselves across these recommendations. Next slide. Also, I'll touch quickly on the remaining slides here, but we are also able to work with these groups to take some surveys of their employees and also of students and families, thinking about fears and concerns around in-person learning, fears and concerns around vaccines and kind of what's next, and to tailor some learning materials and consultations towards that. Next slide. So really since about December, we've been focusing a lot of our work on vaccines, vaccine consultations, and town halls. Again, working closely with our state and with those resources that the state has provided to really provide accessible communication that has removed some barriers to get folks to come and talk to us and have this open conversation with a diverse group of local community health experts. Next slide. So this is our team down here on the bottom left. This is Greenlight Plus, so a lot of folks from our community who really have had an interest in community health and have kind of working with community-based organizations. Many folks here are from community-based organizations who have worked with these groups to host these town halls to address questions and concerns related to vaccines. We put on many dozens of these now with hundreds of participants, and it's been a really rewarding experience. Next slide. Just quickly, we've had the great opportunity and privilege to work with close to 100 small businesses in the area and dozens of schools as well. And I mentioned some of the vaccine work as well across many different community-based organizations with community health workers. Next slide. I think that's all for this morning. I'd love to take any questions if there are.
I think there's lots of questions. I have a ton of questions myself. I'd love to hear more about how you work more with contact tracing and other contact tracing resources. And I'd love to hear more about, you had a bullet point there about vaccine hesitancy and that information. But unfortunately, I think we're a little short on time. So maybe we could have people submit questions. And I'm sure we'll meet down the road. So
Yeah, we can see if there's time at the end to have questions for both presenters too. So let's
Absolutely.
move to Mary Beth. Mary Beth Carrillo, she's from ERA, and I'll let her go ahead and get started.
Great, thank you so much. So thanks so much, everybody, for making space to let us share a little bit about ERA and our IS community. I'll go through this kind of quickly, and I just see this as an intro conversation, and hopefully we'll be able to follow up with any questions you might have. So next slide. You can actually go one more forward. What I want to get across today is just a little bit about the current state of interoperability, and you'll hear me use IS and immunization registries interchangeably. And then if we have time, get your questions answered today, or certainly strengthen our relationship and our contacts ongoing for ongoing communication. So next slide. A little bit about the current state. There is no national IIS, so each IIS system operates independently, but we do leverage national standards, and that's part of, I think, what really brought our early success in the IS community, that we really focused on standards so that we could interact once EHRs and pharmacy systems became more ubiquitous out there. That being said, all IS are still governed by state law and policy, so you will see some variations from jurisdiction to jurisdiction. The oldest IS have been around for almost 30 years now, and I will say one of our challenges in our community, which I'm sure will not be unfamiliar to the FQHC community, is that boom and bust funding cycle. So we are challenged with that of really needing to stabilize funding over time and make sure that we can focus on sustainability and strategic development of our systems. Move to the next slide. I want to just mention that IS are available in every state in the country. We welcomed New Hampshire, which was the most recent jurisdiction to come online. And then we have several city or county-based registries as well in existence out there. And these systems do a lot. On the next slide, I just talked through some of the overall functionality. It's not just capturing shots and dates, but it's really processing, consolidating those records, and most importantly, making them available out there at the point of care for clinical support, as well as across public health, across member organizations, across payers. And so we want to make sure that the focus is not just data coming in, but data being processed, consolidated, and then sent out for use in a variety of venues and by a variety of audiences. We'll move to the next slide. I'll talk a little bit about what's in these systems and where it comes from. We have lifespan patient data, so every IS out there is birth to death now. There was a time when IS were more focused on baby shots and pediatric interoperability, but now they really are lifespan birth to death. So it's that patient data, trying to capture the full patient population within a jurisdiction, and then all ACIP recommended immunizations, including COVID. And for the first time, COVID has sort of a universal requirement for submission to IS. And then also some federal partner data comes in, like Indian Health Services. What is missing from IS right now that we're working on getting into the system is a lot of the federal partner data. So Department of Defense, Veterans Administration, that's not flowing into IS right now, but we're working on relationships and a centralized router that will allow that information to come in. We'll flip to the next slide. I just want to call out that the vast majority of our system are supported by electronic health record data. So prior to COVID, about 80 to 90%, depending on the system, got their data in through electronic health records. And then some additional data came in through vital statistics, being populated with birth data, direct data entry through web-based user interfaces, and then certainly pharmacy systems and other systems that also send data. We've seen that shift a little bit with COVID, where we have more sort of pop-up clinics or small sites who may be doing more direct data entry, but still, by and large, our vast majority of data comes from electronic health record interactions. And in terms of capture, if you'll move to the next slide, we have very, very strong capture for children under 6 because IS really got their start in that pediatric community. But we're seeing it grow. So among adolescents, we're up to over 80% capture. Among adults, 19 and above, we have about 60% capture. This is 2019 data, and we know that that's really changed with COVID and so many new enrollees coming on with IIS. So we expect this to be a lot higher the next time we get a chance to look at the national picture. If we move to the next slide, I want to just briefly talk about some of the areas of variation that may affect interoperability and or functionality that you might see in your IIS. And I mentioned that IIS are governed by law and policy, so that may change who they see as authorized users. In one jurisdiction, they may recognize payers as authorized users. In another jurisdiction, they may not. Consent is also a place where you can see some variation. We still have 3 jurisdictions who are opt-in, meaning that patients need to actively consent to have their data sent into the registry, and that can change the way an IIS operates. Some jurisdictions have mandates to report all immunizations, some for only 0 to 18. And I mentioned the big change with COVID is that providers who administer COVID are required to send their data into an IIS by and large. And then you're also going to see some variations with business needs and maturity. That being said, we try very hard to create a national network of systems that really interoperate seamlessly. And that's really our goal, to make sure that our systems operate in a uniform way. And particularly for those providers who are operating in multiple states, we know that they expect that uniformity as well. We want to make sure that everyone has access to the same high quality data out there. We'll move to the next slide. I just want to give a quick snapshot of IIS by the numbers, because I think that this really underscores how important that standards-based interoperability is. So most of these numbers are pre-COVID. So I mentioned that our national picture right now is really fueled by 2019 data. So we know going into the COVID response, we had about 117,000 active standards-based interfaces between IIS and health systems, hospitals, emergency rooms, pharmacies. And what that looks like on an individual IIS picture is about 17,000 administered doses being reported a day. So if you think about what that means in terms of functionality of processing, consolidating, deduplicating those records, cleaning and maintaining high data standards, that's a lot of movement. What's really interesting about this is that we get about twice the number of queries as submissions across the IIS community. So average number of queries, so a provider looking for that consolidated record or forecast, is about 32,000 per day per IIS. And again, pre-COVID numbers, but if you look at current day, we had a call with some of our California colleagues this week, and on just one day, they saw 570,000 reported immunizations. So that just gives you a sense of how much that volume has increased because of COVID and because we're doing such a great job, and you're all doing such a great job administering doses out there. So I'll quickly just touch on it. I know we've only got 1 minute. If you flip to the next slide, just the COVID response. We recognize one of the challenges of IIS is that they are state-based. So there are a lot of efforts not only to look at how we consolidate data up to CDC to provide that national picture, but also how we exchange data. So I wanted to just call out the IZ Gateway Cloud right in the middle of this, and that really is where we're looking at a strategy for interjurisdictional exchange to make sure that patients can get access to their data regardless of where those doses may have been administered. And if you'll flip to the next slide, I'll just quickly hit on, we recognize, and I added this to CDC's graphic there, that really the strength of IIS and the strength of this whole system on provider org there who are sending in data and using these data at the point of care, because we know that's where the real work happens. So with that, I'll just quickly summarize my take-home messages. That IIS are juggling a lot, and they are committed, very committed. And if you flip to the next slide, I just have a couple quick points. Very committed to making sure that these data are captured in a clean, clear way, and that they're made available at the point of care where they're really needed. So with that, my contact information is on the last slide. I know I have used up our very last minute, but I just want to say, please reach out if you have additional questions, and we're happy to work with you, and we recognize how much hard work you're doing out in the field. So we want to make these data easy and accessible for you. With that, I will wrap up. So thanks so much, everybody.
So I think we could squeeze in 1 or 2 questions maybe. I do want to first call out your attention to our last session in this learning community series about evaluating usability and human-centered design. That will be led by our physician informaticist, Raymond Uwe. and it'll be on May 11th at the same time, 11 a.m. Eastern. So we have a question. I think it's specifically to Greenlight, but I think Mary Beth, if you have a follow-up comment, you certainly could sort of talk about the same workflow. So the question is, can we talk about what the benefit is to health centers in participating in Greenlight? Does it help to support things like acting as an immunization record system, or is it a data reporting depository for data only sort of around the community health worker data capture? For example, could Greenlight be used to help sort of act as an intermediary IIS system if they had a patient who got a first dose somewhere? Could they use Greenlight to sort of record the need for a second dose and then transmit that information back to the health center?
Yeah, that's a good question. Thank you. So we have not used, Greenlight hasn't been used in that capacity at this point. It's been more as a way to sort of connect folks to the social services, as I mentioned. We have been working with community groups to actually, help set up some of these vaccination events, particularly, in specific communities, but we haven't actually used it as a kind of vaccine dose repository from a data perspective.
And so, Mary Beth, can you answer a follow-up question for us? So for that kind of challenge, right, figuring out where patients have been vaccinated, who might be missing a dose, who maybe needs outreach because they haven't gotten any doses, how does the IIS help you with that? And how could health centers connect to the IIS in a way that would help them to figure that sort of thing out?
Yeah, that's a great question. So nearly every IIS has reminder recall functionality. Some of that is centralized, meaning it's conducted by public health, but many times that's actually available for providers to use as well to capture their provider population and outreach to folks. One of the challenges is that people do maybe get first dose in one place, second dose in another place. So if it's within the same jurisdiction, that's where an IIS can be really helpful for querying in advance of providing an additional immunization to find out, oh, they got their first dose at the pharmacy, and so the second dose now can be given in our clinic. We are working, though, on that IZ gateway routing that will allow us to query across state lines, and that is actually active and in production in a number of jurisdictions right now. And what we really want to push for is making that ubiquitous and available everywhere. So a provider can say, hey, I'm in North Carolina, but I recognize that my patient got their dose in DC, and query that across. So that's coming slowly. And I think we're active right now in about 6 or 7 jurisdictions, and hoping that with the big push and the recognition of how important COVID data is, that we can really make sure that that's available everywhere.
And so if I can, in sort of my final comment, put out a challenge or a request to all of you. If you're interested in getting on board with the IIS system at sort of a fundamental level, feel free to reach out to the NAC team, and we'll help to connect you with ERA and the local jurisdiction that can help you. If you're a sophisticated user and you have a large, an important use case where you're right on the boundary of 2 states, for example, I think we would be happy to hear about folks who are really interested and think that they would be ready to move and getting in the queue for the IZ gateway. And then if you're interested, or if you have ideas about how to use an interface like Greenlight, or about how we could leverage the NAC informatics infrastructure Cosmos that John talked about, please reach out to us. You can reach out to us at informatics@nac.com, or you can reach out directly to jskapik@nac.com, and we're happy to follow up. Please continue to join us in the learning community. We're happy to answer any questions. You can email us again at either of those emails, jskapik@nac.com or informatics@nac.com, and we'll get back to you and look forward to following up with our last session on usability and human-centered design on May 11th. Thank you so much for everything that you do, and keep fighting the good fight on the COVID vaccine and COVID front for us in the community.
Absolutely. Thanks everyone for attending, and a special thanks to our presenters.
Thanks, everyone.
Thank you.